Continuando con la introducción que hicimos ya ayer al uso clínico de la patología digital, ayer vimos un enfoque basado en el uso de preparaciones digitales, en este caso fue para el cáncer de próstata. Y hoy vamos a ver cómo todo ese análisis, todo ese estudio que hace el patólogo de forma manual también se puede automatizar. Y en ese sentido, pues, gracias a la colaboración de General Electric, pues tenemos la suerte de contar con el fundador de la empresa Visiofarm, Michael Grunkin, que nos va a dar una visión de cómo estas herramientas pueden ayudar a aumentar la objetividad y la productividad del trabajo del patólogo utilizando el análisis de imagen automatizado. El título de su charla es el estudio de la expresión de la proteína ER2 en cáncer de mama, valorando tanto la morfología de la membrana como la correlación con la amplificación genética. Él va a dar la charla en inglés. Sé que la mayoría de vosotros no tenéis ningún problema. Ya le he comentado que sí, que no tiene por qué hacer el esfuerzo de hacerlo en español, que en inglés creo que lo vamos a entender. Así que, Michael, thank you very much for coming to talk about these tools about ER2 protein expression. So, thank you when you want.
Well, thank you very much, and good morning to all of you. I hope that this microphone will work. First of all, thank you to the organizer for allowing me to come here and present to you today. I would like to start out by apologizing. My Spanish is very, very poor, so I will do this presentation in English. I have learned through many years of academia to pretend that I understand Spanish. Of course I don't. But so anyway, I also wanted to thank Omnix for allowing me to share this presentation slot. We have worked together for about 18 months now on implementing our algorithms in their workflow software. We are developing, Visiofarm is a cancer research and cancer diagnostic company. So we work with image analysis, both for cancer research and cancer diagnostics. What we will focus on today in this presentation is a fairly small part of that work, but still, we believe, an important part of this work. And as stated here, I will be talking about the HER2, which is part of the breast cancer panel. I understand that you talked about prostate cancer today, and we'll be talking about another very large cancer type, which is breast cancer right now. All of these apps, we call them diagnostic apps, have been implemented in the Omnix system, and we expect all of these algorithms to go live early next year. So right now, you will not be able to see a demo in the Omnix system out there, but if you're interested, I can certainly offer you a demo. So there is HER2, of course, which is very, very important for reasons I will be talking about today. And then we have the usual suspects of ER, PR, and there is, of course, also Ki-67. Mitotic counting is extremely important, and it's growing in importance. I will not talk about this today. This is also becoming CE marked, which means you're allowed to use it for in vitro diagnostics. Now, this is what they look like, these different algorithms in the Omnix user interface. I will only focus today, because time is limited, on the HER2 aspect. And because we do believe that HER2 is not only extremely important, but there are very significant benefits to using image analysis with HER2, and that's what I'll try to talk about. But those of you who have worked with digital pathology for a number of years may want to ask, why do we need another algorithm for HER2? There are already several algorithms out there in the different system. So first of all, let me talk about the significance where we see that there is something to be gained when we talk about HER2. Most places in the world where you're looking at HER2 to determine what kind of treatment is a woman, will she benefit from a Herceptin treatment or not? You have this sort of paradigm where initially you will start looking at the protein expression using HER2 IHC. That seems to be logical because it is the least expensive approach to this. And if you're using the protein expression, you can either be negative, which is the usual 0 or 1 plus, you can be positive, but, there is a significant amount of the patients that end up in the 2+ group. We have been doing validation at 20 different pathology labs. And there is about 20% of all patient cases that end up in the 2+ category. So if you end up in the 2+ category, it means that you will go on to HER2 gene amplification. And by the way, HER2 gene amplification is the gold standard we know today. There is nothing wrong with going to HER2 gene amplification to determine whether in fact you are positive or negative. The only problem is A, it's very expensive. B, it's also very time consuming, so you extend the time before the patient gets the answer. And everyone who has worked with patient knows what that extension of maybe even a couple of days means. So what we do want is any algorithm that helps us read and interpret the HER2 protein expression should be accurate. Give us as few 2+ as possible, but also be correct in distributing the patients on 0 or negative and positive, which in other words is we want a high diagnostic accuracy, a high sensitivity, and a high specificity with respect to gene amplification. So when we're trying to interpret HER2 protein expression, the ASCO-CAP guidelines that have been issued recently, a renewal from 2013, is telling us how should we interpret, how should we read and interpret HER2 protein expression. And that's being incorporated in guidelines across most of the world, certainly not just in the United States, but even here in Europe. So what does it tell us? Well, it basically tells us that the HER2 score is a function of two things: intensity and membrane completeness. And when we start talking about intensity, it can be intense, it can be moderate, it can be weak, faint, or barely perceptible, whatever that means. And earlier, we just needed to talk about membrane completeness, circumferential staining being complete or incomplete. Maybe you could interpret that. But the big problem is that now, with the new guidelines, we have to look at degrees of completeness. And in a world that really is asking for standardization, that's not necessarily helpful. And it also leaves us with a number of unanswered questions. For example, if we're looking at intensity and completeness, how much do these two evaluation criteria really contribute together and independently? And there is no standardization of intensity or completeness. What does it mean that something is weak or strong? That's another problem. And how do we standardize the completeness or even quantify the completeness of circumferential staining? And there are even some problems that if you start, as we did, developing algorithms, you will start tearing your hair because we are cutting through three-dimensional tissue. And sometimes you see a membrane without a nucleus. And sometimes you see a membrane between two nuclei, and does it belong to both or just one of them? So as you can see, there are plenty of unanswered questions even in these ASCO-CAP guidelines that is only trying basically to give us a cognitive interpretation of how people normally read HER2, but it's not a good platform for standardization. Then we can try to look at what's out there. That's what we started doing already back in 2005-06. What's out there? What has been validated? And there's an excellent review paper by Dobson from 2010 that is reviewing all these different commercial algorithms. And they even listed the performance data from these different algorithms where they have measured concordance with manual reading. And oh, that's one of the problems. All of these different algorithms were really, their performance was measured as concordance with human reading. Now, HER2 is one of the few things where we do have a gold standard. We have gene amplification, and none of these methods were actually correlated with gene amplification. That's one thing we wanted to do. Most of these algorithms are really based on intensity only. So Dobson paper here was the first that showed, well, maybe there is something to be gained by looking at membrane morphology. Let's do that. And they showed that by including membrane morphology, we could increase the diagnostic sensitivity and specificity with respect to gene amplification. But they didn't say what that membrane morphology is. There is also the obvious limitation that most of the algorithms are very closely tied with one specific reagent vendor. So we set out to create a universal principle where you could be independent of the different stainer platforms, because anyone in a lab knows that you may have to change reagents over time. So basically, we wanted an algorithm that incorporated membrane morphology based on a universal approach to this. We wanted to understand what role does membrane morphology versus intensity play, and intensity is a big problem because it changes constantly from scanner to scanner, from day to day. So we wanted to know if we could limit that influence of intensity variability. And we wanted to have an algorithm that worked across all the different reagent vendors. So how does it work? I don't have enough time to go into excruciating detail, and you should probably be grateful for that, but I'll just give you a flavor. The idea that we arrived at after years of research was really say, let's find a principle where we can really find all positive membrane objects. And it means that it has a positive staining. It can be weak, it can be strong, but there is a positive staining, and it is locally linear. That means that it's a membrane object. And when you look at negative cases, positive cases, and 2+ cases, you can see that there is a size difference in these membrane objects. If it's a 3+ and you have many neighboring cells, you would have very large connected membrane objects. If it's negative, they're very small, if there are any at all, and they're small and dispersed. So we decided to look at size distribution, and what you look at here is size distribution. And by the way, the study's design was to take serial sections of all these tumors and stain them with pathway and Herceptin, Hercept respectively. With the same settings, you can see that we have 3+, we have the negative cases, and we have the 2+. So just looking at membrane morphology in terms of size distribution apparently allow us to discriminate between these cases quite well. Well, how well? Well, it turns out that when we correlated in a multiple regression model, intensity and connectivity, this size distribution is what we call connectivity, and it's a generalized membrane completeness. Then we did a multiple regression where we said we both have intensity and connectivity, and we wanted to predict HER2 fish. And it turns out that intensity does not contribute statistically independent information to the connectivity. In other words, it's enough to look at connectivity if we have detected membrane objects above a certain detection threshold and just look at the size distribution. This is enough. So in other words, we can get rid of the one component in digital pathology that gives us most variability, and that is intensity. So we've done some publications, of course. This was the seminal paper back from 2011 that describes all the wonderful technical detail about the algorithm and also gives you some basic performance data. And here's some performance data on 250 tissue specimens that we looked at originally. What's interesting about this slightly busy slide is that we get a very, very high sensitivity and specificity with respect to HER2 fish. Well, that's good because that's what we wanted. What we also wanted to show was what is then the concordance with human reading. And in this case, human reading means 5 independent pathologists, all from Nordic QC. We developed the algorithm with Nordic QC. And when they differed, there was a consensus reading. So we could now compare image analysis to the consensus score of 5 independent pathologists and arrive at a certain percentage agreement and Cohen's kappa for the Hercept test and the pathway. They're quite high, and what it means is that pathologists are actually very, very good at reading this. But still, they could not achieve the same sensitivity and specificity with respect to the gene amplification. And this is not just a cognitive issue. It's also because pathologists, sometimes that's what we hear, I'm not a pathologist, but pathologists tell us that sometimes we are in doubt and we want to give this patient an extra chance. So since then, we have collected data from more than 170 laboratories, so we're quite sure that it's robust and that it works. And we also have a package insert that tells you that it works for Daco-like and Ventana stainer platforms. It's been validated across the different scanner platforms, of course, including the Omnic scanner, where it will now be released early next year. And what is important, we have heard, is that it truly allows diagnostic pathology labs to choose between the different stainer platforms. So when I've presented this to pathologists all over the world, what are they really asking for? Other than science, of course, because science and validation is extremely important to pathologists, it's very important to oncologists. But what else are they asking for? And generally, there is one common answer. Show me the money. What can we do? Pathology labs are under tremendous pressure. The caseload is increasing. The complexity of tests, because we are getting more personalized treatment, is increasing. In Canada, the workload increased by 65% over a 10-year period without no extra funding. That's what we're looking at. So show me the money. That is a very, very reasonable question. So I'll try to show you money, at least for this one biomarker. We have a whole range of other diagnostic markers, but for HER2 just. Let me just, this is a very busy slide, I apologize, but try to focus on this one. This is from Copenhagen, data from Copenhagen University Hospital. We are doing a national validation study, and this is by far the biggest hospital. Initially, we were looking at 312 tissue specimens, and Since then, we've been looking at many, many more. And what you see in this column is the routine scores. That means out of 312, 53 were inconclusive 2+. That's what oncologists love, right? When it's inconclusive. So 53 were inconclusive. Now, when we subjected this to image analysis using the HER2 Connect, only 6 were inconclusive. And when we look at these individual cases, it means that we reclassified 46 out of 53 as being negative. And when we checked the gene amplification, they were all FISH negative. So they were correctly reclassified. 2 of these were reclassified as being positive. And when we checked FISH results, they were both positive. So in other words, we can reduce the inconclusive cases here with almost 90% without losing sensitivity or specificity. So I was touring the world talking about this and came to, this is actually St. James Hospital in Ireland, and they said, all right, instead of you talking, Michael, and PowerPoints, let me send you 61 cases and see how it works. So they sent us 61 cases and the routine scores. 14 of those routine scores were actually 2+. And we recategorized 8 as negative, they were all negative, 3 as positive, all 3 were positive. So in both cases, we could reduce the amount of inconclusive cases significantly without sacrificing sensitivity and specificity. What does that mean? Well, it means that there's actually money to be saved, not just time. Time is really important to the patient. It's important to the metrics that you're being measured on. But if you look at the cost of doing reflex testing with FISH, it's about 240 euros per test. Now, we've looked at all these different pathology labs, and as I mentioned in the beginning, about 20% are actually 2+ cases. So across those 20 labs we were looking at in our validation study, we could actually reduce with at least 75%. So that means for each 100 breast cancer patients you're seeing in your labs, for each 100 cases, 20% will be a 2+. If we can reduce that with 75% at a cost per case of 240, it means that you can save almost 4,000 euros in reflex testing per 100 patients. That's a lot of money in most pathology labs. If you're doing 400, 500, 600 breast cancer patients per year, and a lot of you probably undergo the same trends that we see in the rest of the world, consolidation of pathology labs. In the United Kingdom, they went from 300 to 200, and they ended up with 30. I don't know what it's going to be like in Spain, but you will have fewer pathology labs with a very large volume of patients, and that's when this begins to matter. And this is just, again, let me emphasize, one marker. There are other markers, and there are other ways to increase the productivity of pathologists. So today, we are implementing this all over Denmark in one big national validation study. And it's not just, of course, the HER2, it's the entire breast panel. We are also implementing a panel for malignant melanoma. We are implementing a panel for prostate cancer in workflows that not just make the data much, much better, but also increase the productivity of the subspecialized pathologists who are really a scarce and valuable resource. And we're also beginning to implement this now in Sweden, in Ireland, in Netherlands, and many other places. So thank you very much for your attention, and I know that time is limited, so if you have additional questions, feel free to email me, and I'll be very happy to answer them. Thank you.
Perfect. Thank you very much, Michael. ¿Queréis hacer alguna pregunta, algún comentario a esta presentación de análisis en ER2? Sí, Luis, por favor.
Question. When you deal with automatic systems analysis and use the chemical techniques, sometimes you ask what's going to happen when you have different slides, I mean thicker slides and thinner slides. Is this, are there influence in the results when you use automatic systems of validation of these techniques?
So you're asking that there are many different parameters that could cause variability, and one of them obviously is thickness of slides, and that is definitely true. And the way that algorithms are being influenced depends on what biomarker you're looking at. Is it a membrane marker or is it a nuclear marker? If it's a membrane marker, we don't see a lot of variability as long as you stay within, I guess, 2 to 6 microns even. And the reason is that we are not dependent upon intensity. So since we have eliminated intensity from the membrane algorithm, we become less sensitive to that. It's a different story if you're looking at nuclear markers, because when we're looking at nuclear markers, we have to determine for Ki-67, for example, which nuclei are positive and which ones are negative, which, by the way, nobody have really dealt with in a systematic way. For the hormone receptors, we even have to translate this into H scores or all red scores, and then it becomes different. What we've done there, and this is no perfect solution, for the hormone receptors is really the most difficult. But you normally have control slides or control sections on your slide. And if your control section has the same thickness as your test section, then you can use the positive control to normalize. So that's one approach. To what extent it's really waterproof, I don't know. I think we have a better answer for the proliferation markers, specifically Ki-67, because you always have positivity in the tumor, so you can do internal calibration. So you find the 1 to 5% most positive nuclei in the section, and you normalize with that in determining whether it's a positive or a negative nucleus. So where I have the most doubt as to the standardization right now is really when it comes to hormone receptors, if we insist on having all red or H scores. In Scandinavia, for example, they're only looking at positive fraction. And if you're only looking at positive fraction, you become less sensitive, but I don't know how much information you're losing there.
Thank you. ¿Alguna otra pregunta? Michael, I would like to ask you about the integration of the information that you get from these algorithms. Are people integrating this with the LIS? And another question is, I'm worried about the time that it takes to do all these algorithms, because then you have to do it in many cases. No? Is the system able to discriminate between invasive and non-invasive cancer, for instance, or do you have to do it manually?
Right. That's a very important question you're asking there. So obviously there are 2 ways to do this. And what I just described here is a field of view based approach where the pathologist is selecting a field of view and then eliminating stromal cells and then also ductal carcinoma in situ, as the case may be here. And there I have to agree with you that it's not evident that you will get any productivity increases, and that tends to be a problem. We have developed a system internally at Visiopharm that we are, by the way, also discussing with Omnix about integrating that. But we call that Oncotopics DX, And what Oncotopics DX does is that it can automatically identify not just invasive tumor cells, well, it excludes stromal cells, and you can even identify ductal carcinoma in situ. And this is really important, because now you can focus on the tumor cells, on the right invasive tumor cells. And then you can evaluate your algorithm only for the tumor cells. We are using a new principle that I don't have time to talk about called virtual double staining to identify the tumor cells. But what this means is that you can do workflow reassignment in the lab, that you can push a lot of the work to technicians. The technical aspects of the image analysis work can be pushed to the technicians. They push the results to the LIS or the Omnic system, and then you open up the results, your work list, and then you look at all the cases that have been analyzed. Now, and this is in a case-based reviewing, so you're looking at all the markers at the same time, they're synchronized and all, and that means the results are there. They're shown on the slides, and you move to the next. This is what we're doing all over Denmark, and we have significant productivity increases because we can do workflow reassignment in the lab because of this automation. And this is all either directly or via, for example, the Omnic system integrated with the LIS systems. And we currently have very minimal invasive integration model to the LIS systems, and that reduces the time and cost and risk of doing the integration.
Thank you. Very interesting. Any other question? Cualquier otra? If not, thank you very much, Michael.
Thank you very much.
Very interesting. Thank you for the effort.